Hello, I'm Christina Hickman, the Chief Clinical Officer at Fertility. So welcome to today's AI Academy supported by Fertility. I have the honor and privilege to introduce today's talk and lecturer. Dr. Gerard Letterie is a reproductive endocrinologist, partner at Seattle Reproductive Medicine in Seattle, Washington. He's also the co-founder of Step Analytics. He completed his training in obstetrics and gynecology at Walter Reed Hospital in Washington, D.C., and a fellowship in REI at NIH. He has served on educational committees within his subspecialty and specialty of obstetrics and gynecology. He is a reviewer for journals, including Fertility and Sterility, JARG, and RBMO Online, among others. He's also the author of publications on the topics of clinical care, medical liability, and artificial intelligence in peer-reviewed journals, including abstracts, reviews, and several editorials and op-eds. He's also the academic head of this very AI Academy. So with no further ado, Gerard, over to you.
Welcome to the next session of the AI Academy. My name is Gerard Letterie, and I'm a reproductive endocrinologist in Seattle, and I'm reaching out to you from our offices here at Seattle Reproductive Medicine. And my topic today is talking about transitions in the way we make decisions and looking at this combination of clinical expertise, evidence-based medicine, and artificial intelligence. And what I'm going to do is give you a little bit of background to talk about how we change the way we decide what's happened over the years and transitioning to a point where AI will become an integral part of what we do. The lecture will be divided into three parts, talking a little bit about the context of our decision-making in clinical medicine. I'll discuss briefly two AI tools that we're working on, one with preliminary data for stimulation protocol, and a second that we've looked at in from various perspectives on workflow management, and that's a published manuscript and presented. And finally, I'll talk a little bit about the future and what I personally see, and I think there's substantial support for this in the literature, about how patients will be viewing what we do, and finally, what we as clinicians and embryologists can expect from AI as we move forward. 3 slides to give you some perspective about this triangle of expertise, evidence-based medicine, and AI. The first one is this as a point of history. This is a presentation on DES, or diethylstilbestrol. This was a godsend for practitioners, and this established one way of managing miscarriages and complications. But I'm going to read to you a comment made by a participant at this presentation. Dr. Smith was a prominent GYN at the time. The mere fact that Dr. Smith is proposing this as an effective treatment is sufficient, in my opinion, to recommend its use. This was at the time gospel, and this is how people practiced. It was the way you were trained, what people told you to do, and effectively what you did in carrying that forward. That changed in 1992. This is a publication from JAMA talking about evidence-based medicine. And this was a completely new paradigm, saying that decisions should be made based on the literature and the quality of the evidence. And this is completely changing thinking at that time. That's 1992. I dare say that there are still people that practice using solely expertise and ignoring evidence-based medicine. But it took quite a long time to establish EBM as the gold standard for decision-making. I'm going to propose to you that AI will be the third tier in decision-making that's going to drive this. This is an NIH statement saying that AI tools have shown promise in predicting patients' health trajectories and emphasizing that it has the potential both to reduce workload and increase efficiency of administrative tasks. That's going to be the way we make decisions in the future, I would suggest to you, and it's going to become more and more embedded in what we do. We'll transition now and talk about the two tools I mentioned to you, but I first want to place this again in a context. I'm going to use the term legacy in this lecture, and in computing, legacy refers to an old methodology or technology, something that's in the past, even outdated hardware or computer system, yet still in use. So this concept of a legacy is prevalent in other areas, but it's not the way we want to practice. Basically, a legacy system is out of date and in need of replacement, And I'm going to suggest to you that that's where we are right now. We make decisions largely based on experience and evidence, and that's great. But I think the burden of proof will be on us as literature and data expands. The number of publications is exploding, particularly in assisted reproductive technologies, that we're going to need a system for sorting that and coming to conclusions about best treatment, best outcomes, and our best ability to guide patients in their decision-making. And moving forward, in an EMR, in an AI-driven system, we should expect the following: getting a personalized plan from profile of the patient when they present to us, what, for example, their AMH is, through treatment and image analytics. Each of these steps from start, middle, final in the embryology lab should be guided with AI tools. It's not immediate, it's not going to happen tomorrow, but that's what I think we should be looking forward to up on the horizon. It provides us as practitioners the ability to guide patients in their decision-making. So rather than me sitting there and saying to a 38-year-old, your likelihood of success is X based upon solely maternal age or some other factor, we're going to be able to give them segmented, broken down likelihood of success stratified by different treatments. And finally, as you'll hear with Dr. Harrington, who's presenting also in our AI Academy, smartphone connectivity is essential. I'll mention that briefly as we move forward in the latter part of the lecture. I've broken down this whole process into the 5 larger blocks that you can see here. Devices for the patient's profile. We have 3 devices for stimulation in the lab regarding protocol profiling and the image analytics, and finally some workflow. I'm going to focus on protocol selection, trigger options, and oocyte prediction, how many we're going to get, both total and mature, since we're relatively restricted in our time. But there are tools that are evolving, if not in place already in the literature, for each of the bullet points that you see here, each of the 10 bullet points that are captured in the 4 blocks. Before we start talking about the 2 tools I'll describe to you, we set about asking a question. How much data do you need to make a decision to train a system? What's the driver? Is there one single test that's going to guide predictions in a cost-effective way? So imagine if we could get one test, for example, AMH, which I'll focus on, and not do an ultrasound or FSH or estradiol or any of the other add-on tests. If we could have one single test, that's a significant cost savings and a convenience for the patient, given that you can have these tests done online with a needle stick on your fingers and a cardboard blood dot, and have AMH analyzed. We looked at 15 features, and we did this on 3 separate occasions with 3 different databases. And we looked at ordinary least squares regression, stepwise regression, partial least squares regression, and a more recently described analytic called least absolute shrinkage and selection operator, commonly known as LASSO, asking the question, which of 15 features can drive this decision-making and training a predictive model, and can we basically do away with the others? And we came up with this graph. This is a composite. You can see that AMH far and away does all the heavy lifting. In terms of its relative importance, it dwarfs anything else, including age, which is second high, but it's not even close. So, as I said, we've looked at this at 3 different databases. We used AMH as a driver in our decision-making in the next 2 tools that I'll describe to you. I'm going to pose this as a question, and we'll start with discussing stimulation protocol selection. We ask the question, can we define the best starting dose for ovarian stimulation? The legacy, and I'll speak for myself, I look at a patient's chart, age, AMH, FSH if it's there, antral follicle count, use my experience, use what's in the literature, and make a decision about dose. This is personal preference. I venture to say that most of us operate that way, although there are some relatively straightforward and simple tools out on the market. One of them is drug company sponsored that can give some guidance. But our goal is to get away from legacy. Our problem here is in trying to define the best protocol, the populations are very diverse. The factors contributing to infertility, although we do understand it considerably better than we did in the recent past, there are still black boxes, complete unknowns about why the sperm and the egg interact and what we can expect in terms of embryos. And when we have databases, there's significant diversity among the way providers prescribe. The question I'm asking is, does AI offer any advantage? To the point about personal preference and expertise, I randomly went through a database of about 3,000 cycles and just pulled off patients that I thought were relatively comparative. In their 30s, as you can see in the first column, relatively reasonable BMI, similar but not identical AMHs. And then I looked at the prescribing patterns among 10 different physicians. And you can see that it's remarkable, the diversity. It goes from 150 to 375 for patients with similar profiles. So this is a practitioner sitting at a monitor, deciding what to do based on experience. The diversity is amazing, and I dare say that the outcomes are also influenced by dosing. Those in the European Union prescribe at much lower doses than here in the US, so don't be surprised at some of the doses you may see. We looked at about 3,000 cycles across 12 providers. As I mentioned earlier, we used AMH as the input variable. The two output variables were peak estradiol and mature oocytes. We did have data regarding blastocysts, but I want to emphasize to you that this is a preliminary study and it will require further tuning. So I'm sharing with you data, not conclusions, just impressions for the purpose of discussion and illustrating how AI might interact with us as practitioners. Our machine learning model was K-nearest neighbor, or KNN. My thanks to my co-investigators, Professor Kenneth Rice and Michaela Tang at the University of Washington, and we're preparing this manuscript once we get the data more fine-tuned. So in the KNN model, we asked the question, okay, for a particular AMH, and we stratified this based upon these intervals in the first column, what's the average number that we can expect in a patient with an AMH of 2.6 to 5, for example? I'm not going to go through all of these with you, but just to give you an example. And you can see with a dose of 150 to 300, relatively stable, starts to drop off as the doses go up. And I can tell you in additional analyses, this really is the trend. As the doses go up, almost regardless of AMH level, the number of mature eggs goes down. If we then look at peak estradiol concentrations, similarly, if we look at the same interval of 2.6 to 5, it's relatively stable across the doses that we use. Again, preliminary data. But the point that I took away from this analysis using this predictor of KNN is that we might be able to predict the lowest dose to give us the best outcome. Defining best outcome is the highest number of oocytes, best peak estradiol, and the highest number of blastocysts. We do have data regarding pregnancy outcome, but that's a little bit more multifactorial, given that male factor is kind of integrated in their biopsies, no biopsies. That will be part of our final analysis, but for our purposes, the data presented here is peak estradiol and number of mature oocytes. So based upon this preliminary data, the goal here, again, was to have an AI-driven guidance, identifying the single best dose. From this data, we also did look at AFC and age. There's really no relationship to dose and these factors. There's a trend towards higher doses with AMH. Again, in the KNN training, we used only AMH. Whether or not we benefit from any doses above 300 in this database, regardless of AMH, is questionable. Interestingly enough, 90% of providers changed protocols the second or third cycle. As most of us know, this is really not going to change outcome. Ovarian response can be relatively fixed. And there's no trend among the MDs. The providers that I looked at were completely disparate in their prescribing patterns. So this is legacy, and our goal is now to move away from that. Using this simple technique, KNN, there are others that we're going to look at, but in this project, KNN may offer one algorithm for decision making. Our data also suggests that AMH may be the single best driver, and we are also looking at other machine learning tools and linear regression models as listed there. Practical implications. So not only is this about getting better eggs, better embryos, and higher pregnancies, but it's also about cost. Without going into this, and those of us who are not in the United States are spared what we experience regarding the various pricing formulas, for example, wholesale acquisition cost and average wholesale price. Costs here vary tremendously. If we prescribed only 375 and eliminated all the 450 patients, we'd probably save somewhere from $0.5 to about 1.5 million. And if we restricted the dose to 300, that is 150 less per day, we might save even more, 1 million to 2.8 million. Tremendous savings. Setting aside the entire issue of better outcomes, there's a very practical concern here. If we can have a quantitative AI-driven decision tool, I'll emphasize again, these are preliminary data, but this is the direction we're going to head, I guarantee you. Next, we'll talk about workflow process. Approaching this, I've borrowed some concepts from an assembly line. Really, what we do in IVF is an assembly line process. Taking different products, combining them with personnel, and ending up with a final product. So the workflow is really a coordination of tasks, and in blue I put what we do in IVF to be more specific from the general concepts of, for example, coordination. We're monitoring and trying to decide on trigger day, the specific outcome as a blastocyst and pregnancy within a confined team, the clinic and the lab. Multiple steps are involved, for example, ultrasound and estradiol concentrations with a combination of people, providers, physicians, embryologists. And in this paradigm, admin, clinicians, and embryologists should constantly be searching for opportunities to eliminate bottlenecks and improve the flow, ultimately throughput. So this is basically, in black, is the concept of workflow. In blue, what I've highlighted and what we do is IVF, and it's a perfect paradigm. We ask the question, can we facilitate IVF? Again, this is theoretical, we're modeling this out. The legacy is decision-making by individual staff. I'll explain this in a moment. The goal here was to identify the best single day for monitoring. In other words, can we eliminate the multiple ultrasounds and estradiol tests and have only one day? And can we use that information to further refine an option of trigger dates and predicted number of oocytes so the lab can level load? On the left is our real-time data. This is over a period of 12 months. You can see how it bounces around. Peaks are early, mid, and later in the stimulation. Ideally, we could reduce all of this down to 1 or 2 or 3 visits. This is a model. So this would be the concept behind an AI-generated scenario. That was our goal. Again, identify the single best day for monitoring and use that data, what we observed on the single best day, to influence our prediction regarding trigger days. Similarly, for level loading of oocyte retrievals, this is legacy. For example, yesterday I was doing procedures and I was making decisions regarding trigger days. Today, someone else will do that, independent of context. And it results in this sawtooth in the left panel. And we might do 20 or 15 retrievals one day, 2 the next. From the standpoint of personnel management, level loading in the lab, the graph on the right I would propose is the way to go so that you can level load, have a relatively predictable number each day. And I think we have data to guide that decision-making and improve the workflow in the lab. For this project, we looked at a completely different database of 2,600 cycles, relatively restricted number. Of those, we had 1,500, almost 1,600 complete records. And 80% of the cycles we use for training and 20% for challenge in a typical ML learning and challenge paradigm. we looked at 3 tasks. The best day assignment using pre-IVF profile, AMH. Can we assign a trigger day based upon the pre-IVF profile and follicle diameters and estradiol on the best day of observation? And finally, task 3, to predict the total number of mature oocytes. Regarding output number 1, best day for clinic visit, there was a mean average error of 1.3 days. Interestingly enough, the algorithm that we trained never exceeded the actual day, the ground truth for trigger, which is what we want, so we're not missing an opportunity. The next 2 graphs will demonstrate our oocyte number and the trigger day or the range of retrieval days. There was a variance in that of 0 to 3 for retrieval. Accuracy for the number of oocytes is 0.7 and 0.8. These are using only pre-IVF profile. If we add the 2 data points of pre-IVF profile and number of mature oocytes, it goes up a little bit, but interestingly enough, they are similar, which says maybe we have enough ammunition at the start of this to predict the entire cycle, only with pre-IVF profile. Again, one study, one data set. We need more data, more experience, kind of in the field experience. Output number 3, workflow management. Number of oocytes were relatively stable over 3 possible trigger days. And I think for most of us who are in the trenches making clinical decisions each day, this is pretty much corroborating what we've seen, more casual observations. We can get away with pushing a patient 1 or 2 days without any adverse impact. But this algorithm says that, well, actually, we have a range of 3 days over which we can trigger and retrieve, again, enabling more of a level loading and improved workflow management. They're the 2 algorithms that I wanted to share with you. I want to emphasize one other thing about AI in our field. This is moving very quickly. There are lots of tools, lots of devices that are being rolled out. Our implementation and uptake for this should be relatively cautious. We need marked experience, geodiversity, in the trenches. How does this integrate with an EMR before we can actually claim advantage? I think we'll get there, but cautious uptake is the byword in my opinion. I'm going to move on to another topic about the patient and what will drive our progression towards AI. Information asymmetry. This is a classic example, used cars. The car salesman has all the information, and a potential buyer might be able to look stuff up online, but really is at a disadvantage. And I would suggest that in the past, our patients were at a relative disadvantage, that the clinician or those wearing the white coats, thus the expression I have up there, fall of white coat supremacy, really held sway. Patients look to us for advice, and that is all changing, particularly with the millennials who are going to be in the pipeline for our next generation of patients. I looked up some data from Hearst Publications. Hearst, as you probably know, publishes Cosmo, Marie Claire, magazine Parents. They profile patients in our demographic, those who would be using fertility services. This population opens Instagram about 40 times per day. Expression in this report from Hearst was anything that this was looking at a female population, can do on her phone, she will. Data now, over 100 million women have at least one app for fertility monitoring. Our patients are coming to us armed with information. It's very, very different now. They're going to be demanding better information from us to refine what they've read online. And we're all experiencing this already. I would propose that it's going to become more extreme. This concept of information asymmetry is rapidly eroding. We'll have to meet patients on their terms and offer them hard and fast data regarding their likely outcomes, their treatment options, and matching that to what they want to do personally. Everybody has boundaries. Some patients will do IVF immediately, others never. So the discussions up ahead are going to be very different. Over-the-counter tools will increase dramatically. Wearables will enable patients to track cycles. There are some wearables, as we all know. I'm not that impressed with them, but they will improve dramatically. From our standpoint, we should be able to use this information from these wearables, over-the-counter tools, to guide our patients in decision-making. This will also enable a shorter time to conception. Patients will come in armed with information, ready to make a decision regarding what to do with our guidance and counsel. It's already present in cardiology with an ASCD risk estimator. And these are predictive models for short and long-term disease progression. So if you have mild coronary artery disease, hypertension, any of the cardiovascular factors that can increase morbidity and mortality, you can get a sense of where you stand on a timeline. Same thing for our patients. All of this will be enabled by over-the-counter tools and wearables. Finally, I'm going to spend a moment talking about what we should be able to expect from artificial intelligence. This is just an image from a Deck 10 from Digital Equipment Corporation, 1961-62. Back then, a computer was this complicated system, very restricted in terms of who used it and what we could expect from it. It was usually always a male at the helm there. It's considerably changed presently, more change to come. But now it's completely different. These are intensely personal decision-making tools that we have. And I'm going to go through 3 slides to demonstrate this, about what we can expect from AI, factors that spell success, and what we should be looking for in the products that are rolled out to us. The first 3 points I'd like to make are factors that I think will contribute to success. For example, does an algorithm functionality, is there data to improve the training? Is it an ongoing process? And as we all know, that's an integral aspect of machine learning. Is there an EMR connectivity to enable this? Is there an advocate for adoption? Not within industry, not somebody showing up and saying, I have this great tool, but within the profession. Are we as a group willing to step forward and say that our patients will be better served by these tools? For some, the answer might be no, not really, and others might enthusiastically embrace this. This is yet to be sorted out. And finally, what's the data flow? How big is the pool? For example, in the United States, there's a trend towards consolidation that's going to enable the development of large data lakes or pools, and that, to a point, will improve our ability to train the algorithms. Second of 3 points I'd like to make. I'll pose 3 questions. Does it lower costs, improve outcomes, and improve workflow? That really is where we should be focused. Does it enable, rather than challenge, provider judgment? There's a delicate issue among providers. None of us should feel like these tools are going to supplant us. They're not. Clinical care is far more nuanced. Our patients will depend on us for counseling to embrace their emotional needs. So this is not going to provide a substitute for us, but it is going to provide, I think, complementary information. And finally, can we scale this for widespread adoption? The third slide, how do we evaluate the quality of an algorithm? What are the aspects of the performance of the tool that we're interested in? For example, is there improved throughput? We don't necessarily have to improve outcomes. That's really is the goal. But if we can improve throughput, provide care to a greater number of patients, that really is a worthy goal. Second, is there long-term operational support? Are these tools, once they're in place, supported? Can we pick up a phone, access somebody, complain that it's not working right, and have somebody respond? Because we're incorporating these into our decision-making. And finally, is there a degree of comfort as we shift away from expertise and evidence to an inclusion of artificial intelligence in our decision-making? And finally, I'll end with this. This is an image familiar to most of us. This is the original incubator of Steptoe and Edwards. This is legacy, and we're grateful to those who went before us. But compare this to what we're doing now with desktop incubators. Dramatically different. Things move forward, as I hope they will with AI. I'll end the lecture on that note and look forward to any questions. You can access me here at Seattle Reproductive Medicine, or I'll look forward to meeting you at one of the meetings, ESHRA or ASRM. Thanks very much for your attention. Look forward to hearing the other lectures in the AI Academy.
So thank you very much, Gerard. I mean, what an amazing summary of the journey that we've had as a field today, and not just in terms of technology, but in our way of thinking, in our building of the knowledge, and how we're applying this knowledge into clinical practice, and the place of how AI can support enhancing these clinical decisions. I wanted to open to all the attendees. If you would like to comment, please feel free to remove your mute and add comment. We would love to hear from you as well. So if you unmute, that's a signal I have that you would like to speak. You can also ask your questions on the chat, and hopefully we can get a dialogue going here today. So I see we already have a few questions already. So feel free to unmute if you would like to add some comments verbally. So just looking through the questions. Thanks for the great topic. What are the hardest spaces in IVF to tackle with AI? So I'm going to see, I'm going to ask some brave participants. I see that we've got Chad Clark on the call. Chad, would you like to add some comments to this question? So what are the hardest spaces in IVF to tackle with AI?
I really think it's just the acceptance of our doctors, our physicians, our clinical workforce, and our patients to trust AI, but then obviously providing the right evidence to give that trust, and so I think that's probably the most challenging, right? I think AI is very advanced. We can do a number of things with it, given the right data, given the right training tools, and it's getting better and better. Each and every day it seems like there's more AI algorithm tools coming out. So.
And it's interesting because building trust is not an easy thing to do, and Gerard kind of touched a little bit on the fact that we do need a structure, right? How do we provide guidelines or what's the framework we should be following to demonstrate, especially when we have such diverse types of AI coming into the market? Okay, so the hardest spaces in IVF to tackle with AI. Anybody else want to add to this comment? Okay, I wanted to touch a little bit on, because possibly we have a lot of AI tools coming into areas where the data has already been structured and organized. Now, embryology is one example. With the onset of time-lapse comes the standardization, right, of how the data has been put in. But there are other areas where the data is not as organized, or they're hard. Is that do we not have AI tools in those sectors because the data is not there, or because is it a focus? Do we believe that embryology is a place where the decision making should be made, or should it be andrology? Should it be in the ultrasound of the uterus? I'd love to hear from one of the clinicians. I see we've got Christos on the line. Christos, I'd love to hear your thoughts on why is it that we have the focus on very specific areas of the decision making and not in others. Christos Lamprinidis, if you're able to speak. Okay, I think Christos cannot find his. Does anybody else would like to add to Jason Barrett? Would you like to add to this comment of a fellow embryologist?
The uptake's the problem. Even though it is true, a computer can know more than any single one of us ever. and it can make better decisions based on more factors than we could at any time point, no matter how much time we spent on something.
Yeah.
But that means we
With
have to
tremendous speed.
But that means we have to give the control away, technically. I would say we actually have to learn to control it in a better way so we don't feel that we've lost the control. It is assisting us in it instead of it is taking it.
Excellent view. I once heard this phrase that really stuck with me. This is quite early on my personal AI journey. They told me there are going to be two types of people in the world. There's going to be the people who control AI or train AI or teach AI, and they're going to be the people who follow AI. You know, it was one of my motivators coming in going, well, if AI is really going to be part of our day to day, I really want to be part of molding it so that it becomes a tool that supports and helps us in making our clinical decisions. But it's interesting that both of you bring up not technical challenges, but the human acceptance of AI. I've seen in my journey over time how that acceptance is evolving. I mean, we see now with the onset of ChatGPT. I don't know how many of you have used ChatGPT and tested it out with what would be a typical consultation. And see what types of answers that you get from ChatGPT compared to what you would have given to a patient. I'd love to hear from somebody if they've had an opportunity to have a play around with ChatGPT. So so feel free to unmute if you would like to make a comment. The thing with ChatGPT is it's I don't know if you're aware of this, it's only been trained on something like 580 gigabytes of data. That for me, like, really woke me up, because it doesn't feel like that much, or even though it is text data, it doesn't feel like such a huge data set. And yet the responses, at least for the questions that I put out there, were predominantly, like the vast majority were very accurate. In some ways presented in an even better and more succinct manner than I would have been able to present it, despite my years of experience. So I was quite interested to see if this has been the experience with anybody else. And this is the evolution we're going through, you know. So this is the next step of the process, as we're seeing with based on the presentation that we received from Gerard. So let me just see if we have any further questions on the chat. What should we do to create, develop, or improve the live birth rate? Seems like AI, even advanced, is not the most vulnerable point in that way. So really, the improvement of live birth rates really are going to come from either improved decisions based on what would have happened without AI. And one of the things that I really want to highlight is that it's not a matter of comparing human with AI. It's not a competition between the two. I think what we want to see is a comparison between AI on its own, human on its own versus human together with AI. Paula, would you like to say something? No worries at all. So effectively, that's the direction to go. The idea is not for AI to replace humans. It's to enhance our decision making. And another phrase that I heard in the past, which really stuck with me around AI, was the fact that AI will never ever replace humans in our work. But certainly humans with AI are likely to replace humans that are not using AI. So if there are any further questions before we close the session, I'd just like to give you one more opportunity to ask any further questions you might have, or to add a comment, even if it's not a question. Excellent. Go ahead.
Great. Yeah, this is Jason Barrett. So what I want to say is that, yes, it's going to take human uptake for this. However, It's going to come. It's going to happen. And finding the way to use it in the best way is actually the plan. And so my team and I definitely are in that category now. We weren't before, but we are now. And trying to find. However, I will slightly push back on you that it's not a comparison with human versus AI. At first it is. And us humans, especially those who are as dedicated as we are to IVF and success and everything else, we are in a little bit of a competition to be the best that we can be against anybody else, but also for our patients. And therefore, there is a bit of a competition to this. And we are going to try to beat it. But the truth is, we need to use it to make ourselves better. And that is a very different mindset. And so simply the ChatGPT thing that you discussed, it's going to come. We're not even going to know we're reading the actual responses that it would have generated. We need to figure out how to understand it and use it. And so that's what our next big challenge is, not accepting it, but working with it.
Yeah, I completely accept those comments and endorse them. It's a partnership together with AI, not a competition. And yes, we're always trying to look for the best versions of ourselves. It's making sure that we're providing the best possible standard of care to our patients. And being empowered by AI, I believe is the way to achieve that best version of ourselves. But of course, the AI needs to come in a manner that you can, as bringing back to the original question, in a manner that you can trust the advice being provided, but also ensuring that we're always in the position of supervision. So it's there to give you some advice you can follow or you cannot follow, and identify what are the cases. So it's really the two together that I think is the strongest, not AI on its own, not human on its own, but really the two together is when we get the best of both worlds with the human. Because really, if you look at ChatGPT, if you look at the way it answers the questions, it's not really creating any new knowledge. In fact, it's not even bringing in context in many ways. It is regurgitating in the best possible pattern based on the text that it's being taught in. And it's identifying when you have to think a little bit outside the box, what are the cases, what are the patients where maybe it's because they're diabetic, or maybe there's some characteristic about them that suggests that you might need to go a little bit different to what is routine. That's where AI is not great. And this is where the human aspect together with AI can identify we're less likely to miss important information when the two of them are looking at the data as opposed to just one. Any further questions? Excellent. So thank you very much for all of you for attending. Thank you, Gerard, for the fantastic lecture. Thank you, Fertility, for sponsoring the session. And I look forward to seeing you all at the next AI Academy. See you soon. Bye-bye.